begin talking about the research for private practitioners, actually this term may itself be a misnomer because research is for everybody and this almost remains the same. So research is for all medical experts who are practicing clinical sciences, medical sciences, because finally what we have to do is to provide a quality care to our patients. And whether somebody is a private practitioner or working in a corporate hospital or working in a teaching hospital, understanding of the recent research or conducting a recent research, both are equally important because finally patients remain the same. Surgery remains the same. Whether you do cytoreductive surgeries at your center or somebody do at a tertiary care medical center, the surgery remains the same. The patient profile remains the same. So this means probably the perioperative care also should be the same. And hence, it becomes important to understand the latest updates, which is being published across the world. So that's why this session becomes important for all the medical practitioners. I bring greetings from All India Institute of Medical Sciences. When we talk about the research, when we talk about the recent updates, is basically communicating and sharing knowledge because, as I just mentioned, that we have to keep ourselves updated. And that's why we need to change sometime into a clinical practice because the new techniques, the new drugs, the new strategies may come up. Say, for example, if you are aware of, probably remifentanil has been introduced into the India, Sugamadex has been introduced into India, though it was a couple of years back into the international market. But since it has been released, so we should be very updated that how it should be used safely and as per the indications. And that is what we require, the updated science. And when we say to update the science, we have to read papers. And when I say read papers, somebody has rightly said, if you see the Google, it is something like a garbage bin. Everything and anything can be uploaded onto Google. And the validity, sanctity of, or the reliability of those updates or those papers or those information on a generalized platform like Google may not be appropriate to accept into a clinical practice because many of the things will be substandard and they do not have authenticity. So this means we have to identify science. We have to identify a good published paper. And then once we identify, we have to critically appraise them because many papers may not have been scrutinized very well. There are many journals which are substandard journals, something called as predatory journals. They publish whatever you send it to them. And maybe if they have many lacunas with regards to the conduct, with regards to the statistical analysis, if they are not peer reviewed, they will not have been improved to the standards and appropriate interpretation. Hence, the critical appraisal becomes important to look for the quality of study, to determine the effect, whether it is significant and generalizable, and whether they have clinical translational value into a clinical practice. So this means when we talk about the paper, each person, even if they are freelancers, they have certain limitations into their practice. So they have to do something differently to be successful in providing the best possible care to all their patients. They may be at times working single-handedly. They want a technique which is foolproof. They want a technique of analgesia which is very, very successful. So this means that the successful freelancers have to do something differently so that the limitations that they have into their clinical practice, working solo, maybe sometimes in a small hospital, still they are able to provide best possible care. And sometimes they themselves have to do a research that even at their place, in their circumstances, maybe at times with limited infrastructure, how they can provide quality services to their patients in the best possible way. And that's the reason that the skill set of a freelancer is equally important. Sometimes they have to be armed with an extra skill set so that they can provide best care even in a limited resource setting. And that's why they have, if they want to be a successful, they should be aware of even the research aspects. Now, this is an important paper with regards to the freelancers or those who are working solo practice or even a team practice. Knowing me and knowing you is the importance of networking. And that is what they have mentioned, that When we start having networking like these meetings, these conferences, and as you were saying previously, the person, even though they may be working solo in a small team, not like a big department of 70 people we have in the department and can take help as and when required. But even if you're working in a very small team and if your network behaviors is good, we can always, employ and enhance our competencies. And then we feel lead sense of more fulfillment. And obviously, it gives a better patient care. And once we have a better patient care, obviously we feel that yes, we are happy even in this setup and we are satisfied. We don't want to compare ourselves with people working at other centers or big hospitals. So this type of career satisfaction and even the promotional opportunities or feature opportunities with regards to the professional career, financial careers becomes very important. So this is what I'm emphasizing, that when we say knowing me as a freelancer, knowing others is equally important, so that you have all the contentment of you working as freelancers. As with regards to the paper I was mentioning in the beginning, there are millions of papers which are being published across the world in various journals, and the numbers are increasing. And these numbers are to a large quantity, even for a good journal. And it becomes very difficult to look for all those papers because it will take a lot of time. Even if it's in India, you see this nice graph, documents issued top 5 countries each year. India is again emerging, providing very good papers across the world. And you can see that we are crossing even the US, Germany, and Australia for publishing good papers coming from India, from Indian researchers as well. So this means India should also feel proud that with the good amount of researchers, good amount of people who are sharing their clinical experiences for improving patient care, India is also leading to a large extent. And you can see this whole red, which is there, are the countries which are publishing good amount of papers, and India is one of them. So we should be proud of our country as well. Understanding paper, doing research, and understanding research do have some its medical legal concerns also. Because if something happens in the court of law, they will be asking for the standard of care, the acceptable care. What is the recent updates? If somebody use pancronium nowadays for a surgery, small surgeries, it's not acceptable. We should be updated now. Now, in case if the remifentanil is introduced in India and find a very short-acting opiates, probably we should learn that yes, remifentanil is the drug of choice, even not the morphine. So this means even from the medical legal point of view, we should be able to understand the research well, the evidence updates well, so that we can bring change into a clinical practice, so that if by chance something goes wrong, we are able to justify that we are practicing the right thing. And when we say the right thing, we have to choose the right paper. And when we say we have to choose the right paper, we need to understand that what is the right paper. And how to say right paper, we need to understand the research again. So this means research has both the aspects. Doing a research or reading a research, both requires understanding of research. Now, when we have some clinical problem into a clinical practice, we have to search the underlying literature. We have to discuss with colleagues who again will come up from the literature itself, that what relevant publications will be helping us. And the problem are many into our setup, and it will be peculiar for each aspect. There will be some problems with corporate hospitals, some problem with teaching hospitals, some problem with freelancers or team freelancings. So they will have to identify the problem, and then they need to make a question so that they can identify the solution of it. And this is the quest for newer practice. And this is what is called real research question. This is what called clinical question. And this is what requires understanding of research again. So we need to turn the clinical problem into a research question and then try to look for the answers from the published literature. Sometimes we also discuss with other colleagues who are expert in these areas and try to get a final solution. And this type of converting a clinical limitation, a clinical query, a clinical problem into a research question, again, needs to have a basic understanding of the research. And this is an important line which I mentioned in the beginning also. Perhaps most published articles belong in the bin and should certainly not be used to inform practice, because many articles will be published into predatory journals or they will be uploaded into website without undergoing peer review, editing, and revision. And hence, the signs of trashing a paper are many. And these are the reasons that when we say as an editor, we say as a researcher, there are many reasons that why we say that those papers are not good. Those papers cannot have any clinical translational value. Those papers cannot be used to change your clinical practice because they are unoriginal. The hypothesis is not tested. Different type of study was required. They have chosen the wrong design. They have compromised the original protocol. Sample size is not appropriate. Statistical application is not appropriate. Conclusion is not correct. They have conflict of interest. They have not been written scientifically. They have considered which are unimportant issues. Those are not required for the day. So this means there are many reasons. And how can we understand that these are the reasons for a particular paper? We need to understand the research again. So this means what I have just mentioned, that for every clinician, the research is important, whether to conduct a research or to read a research to improve the patient care. That matters a little different, but it is required for each medical professional to have the basic understanding of research. When we conduct a research, it could be clinician versus researchers. Traditionally, people say that researchers do the study, but I would put in a more clear way that it is just researchers are also sometimes clinicians. In a country like India, most of the research are not done by the core researchers. It is done by clinicians who, along with practicing their clinical practice, do the research. In some Western countries, people get a leave for 6 months, 1 year, 2 years, or they are core researchers whose purpose is only to a research and they do a very limited clinical practice. But then they have a team in which some clinicians are with them, and that's where those teams are important. This is a limitation in India. We can't have a very big team for doing single thing, and hence clinicians are important aspect of conducting research as well. Now, when we say to read a research for a clinician who may not be conducting it, but again, what to read requires appropriate choice, requires appropriate interpretation, understanding of the clinical translation values. So this means even to read the medical update still needs the basic research understanding for all. And this is important. So this is what we say, that it is not for researchers, but for everybody. And when we try to look for the research, why the basic understanding, we need to understand. I already mentioned earlier about why we say that this paper goes to the trash. There is nothing good about it. You need to see all those questions. And this again requires understanding of the basic aspects. You need to understand what was found. Should it be logical? What are its implications for you, for your practice, for your group practice, for your freelancing, for patients? How can we improve further on? And if you do agree with all those aspects, you need to look for the outcomes of the study. There are 4 possible outcomes from any study. It may be clinically important and as well as statistically significant. And that is what you need to identify. There are 2 terms which I am using. When we do a study, something may be having a clinical importance, and some studies may not be clinically important, but they be statistically significant. On the other hand, other studies will be statistically insignificant, but clinically important. So this means these 2 terminologies should be very well understood. P-values of 0.0001 does not mean that it is equally clinical applicable into a study, and vice versa is equally important. So that's why, again, we need to understand a research, even for a clinician, that how can we do that? Once we understand those problems, once we understand the limitations into a clinical practice, we either conduct a study or we see the study into a published paper that addresses your question. And when you see a study, you also need to understand that which type of studies are good for bringing change into a clinical practice. Now, this is the hierarchy of the studies that are published. Usually, to begin with, there will be a small case reports or a quiz series, then probably an observational studies or a cohort studies. These studies do not have very robust concluding statement. We need at least a randomized controlled trial for the purpose of saying that, yes, something concretely has been done and it can be applicable. But sometimes even those randomized controlled trials, single trials, would have been done into a selected population may not be applicable to your population. That's why we need a meta-analysis in which many RCTs would have been combined into one, and the analysis done to look for the beneficial effect of a drug or an intervention or a strategy, anything. And that's why meta-analysis, systematic reviews and meta-analysis remains on the top of the hierarchy of evidence. Similarly, when you look for your primary research questions or secondary research questions. Primary is basically you do a scientific study actually directly. And secondary is when you try to analyze, that which mentioned about the meta-analysis or systematic reviews. You try to combine any other researches and try to come up with some single point, single conclusion for beneficial effect or a limitation of a particular step, drug, technique, strategy. RCTs remains always the gold standard because of its inherent contents, which makes it acceptable to all of us. Now, once we understand the material, we understand the limitation, we have a research question, we need to look for the literature. I mentioned at the beginning that probably platforms like Google will give you everything. It will be like a trash, it will be like a garbage bin, and you will get anything and everything. So we need to look for the right place to look for authenticated, probably validated literature, which is very well peer reviewed. And the platform like PubMed is one of them. And you can also look for, say, Cochrane Library, Medline, Scopus. So these are the places where you should search your clinical problem or research question that you want to bring change into a clinical practice. Now, once you have paper, once you have research, you have identified it from the correct website like PubMed, you need to critically appraise them. And critical appraisal has certain important things. So when you do a critical appraisal, there's something called PICOT. So when you create a research question, it has to be into a certain format. Say if you want to look for into a clinical practice and you realize that your patient is recovering 10 to 15 minutes late, even after the reversal of the residual effect of anesthetics, you want that 15 minutes is too long, you need to reduce it, you need to use certain other drugs. So probably this is a limitation that why your patient has delayed awakening, why the extubation is having delayed, or your analgesia techniques is being provided to the patients, but still patient is suffering from pain. They have an NRS score of 5. You need to think that is my technique not appropriate? Do I need to change it? Do I need to change some drugs? So this means these type of questions, just simple question, is my technique appropriate, is not the right question. This is a clinical problem. But when you want to critically appraise it, you have to put in a PICOT formation. So, and this is equally important if you want to do a research also. So I'll be talking both the things simultaneously for the freelancers here, how to critically appraise a paper. And if in case you want to do a research, again, you have to put a research question in PICOT. So both will be applicable for both reading a research or conducting a research. These aspects will be applicable. So when we say PICOT, it has 5 components. And when you frame a research question for reading or conducting of your clinical problem, it should have study population, it should have intervention, it should have comparator or a control arm, it should have outcome, and it should have when those outcome measurements has been done. It has to be mentioned. Say, for example, population, you have to define that, adult, geriatric, gender issues, type of surgeries. So you should mention it because a study done in geriatric patients may not be applicable to infants. Similarly, a surgery which is lap cholecystectomy may not be applicable to open cholecystectomy. So this means you have to define it clearly because one thing is not applicable to the other aspects, and hence you should understand it. Similarly, the drugs, you need to define the drug. If you are using fentanyl versus morphine, you can't say that opiate has this side effect because each opiate, whether it is sufentanil earlier, now fentanyl, remifentanil will be available now in India, morphine. So these will have different outcomes, different effect, different durations, different complications. So hence you should be very clear that what are you looking for? And it needs to be compared with somebody. I cannot say drug A is better. Drug A is better as compared to what? Technique A is more safer. Technique A is safer with respect to which technique? So this means we need to compare with something. And we cannot compare anything with anything. It has to be compared with something which is gold standard, or we should at least a standard of care, an accepted standard of care. And then only we can say that this standard of care, this new drug is good. So probably we need to change our practice, and this is what you need to look for. Similarly, outcome needs to be very well defined. What are you looking for? If you're looking hemodynamic effect of a particular drug during laryngoscopy, you should look for how are you going to assess the hemodynamic effect, whether it is blood pressure, heart rate, or combination. You need to define. And the time measurement, you have to be very clear. You know that majority of patients will have very intense pain after a major surgical procedure for first 24 to 48 hours. So you need to monitor those things. If some study has mentioned about 7 days, that is more of a chronic pain. That is not helping you for the acute pain management. And the reason are different for both. So this means if you look for acute pain management, you need to look for studies which have measured the outcomes within 24 to 48 hours or maybe intraoperatively. And similarly, the outcome should be very well defined. You cannot say mild, moderate pain. Now it's a time you have to define very objectively what do you mean by mild pain. It has to be like on a visual analog scale or a numerical rating scale. So endpoint should be very clinically meaningful. It should be very objective. It should be repeatable. So this means until you observe the outcomes appropriately, how can you say that this is better? It has to be very nicely measured using a validated equipment, a tool, or a questionnaire. And hence it becomes very, very important to pick up an outcome which is sensitive to the effect of treatment and can change your clinical practice. Similarly, when we say objectives of a particular study, if you read a paper or if you conduct a study, you should be very clear. For example, if somebody writes to determine the impact of pregabalin in patients undergoing abdominal surgery, this is the objective of a study. Now, this is very imprecise. This is very inappropriate or inadequate to say that this is my objective of a study. If somebody had conducted a study by just mentioning this objective, then we have little doubt that this study probably is not very well conducted. But somebody has reported the same statement into the more detailed format. Now you can see the difference. That to determine the analgesic efficacy of a single dose of oral pregabalin, because it can be of a BD dose, it can be a high dose, it can be a low dose, and all are not same. As compared to what? Placebo, means no pregabalin. When? 2 hours prior to surgeries. Which patient? Adult patients undergoing laparoscopic abdominal surgeries under general anesthesia, not under spinal anesthesia. So this means now this becomes a complete question, a complete objective. If somebody mentions this, then it appears that if the outcome of this study indicates that the patient has better pain control with pregabalin, you can always change your clinical practice and you can give 75 milligram of pregabalin to these patients. So this is how you need to frame your clinical question or a clinical problem into a research question and then try to identify the literature. Or if you want to conduct it, you have to again form in this format. So this is the precise format, and this is what I want to show the difference. When you read a paper, look for these things. If somebody has not done it, this means that paper is not a very good quality paper. The other aspects which you need to see in a paper or while you are conducting a study, what you need to do is there are many things in the method section. If they are not done, they are not good quality studies. Probably they'll not be published. If they have been published, somebody has missed them, or they may be into a very low standard predatory journals or other journals which are not of good quality. So what you need to look for is the patient selection, the sampling, randomization, blinding, concealment, bias, and confounders. So these are some of the terms which I am mentioning. So look for those things. And if you conduct a study, do include into your publications during the protocol itself that you are doing this way. So the basic purpose of methodology is, if you read a paper, if you understand that the study has been done in this format and you can replicate in the same way, this is what a good method of particular study is. If it is not completely informed, say for example, if somebody says BP measurement will be done, but they have not mentioned in sitting position or supine position using a arterial blood pressure or a non-invasive blood pressure, or it's an automated non-invasive or a sphygmomanometer based. So this means if somebody has not disclosed these details, so this means if somebody has measured by the arterial and if you measure by non-invasive, so you cannot compare both the aspects. So it has to be very clear. Next is the selection of study design. I mentioned in one of the points in the trash bin of a published paper is the study design. I said the RCT is the best design that indicates the concluding statement of a drug or a technique or a strategy better than the other. So you have to select a proper study design, and there are ways of doing it. That some studies which are preliminary studies, you do a cohort studies, observational studies, and once you have, these are called hypothesis generating studies sometimes. And when you have some concrete hypothesis, you do a RCT compare with the new technique with the gold standard or the standard of care. Similarly, when you see the studies, you should also where it has been done. If some study has been done in a small center, probably they will be doing uncomplicated patients, ASA1 patients. probably because they don't have a backup of ICU they're doing in a small center. But if some study has been done, maybe similar study, into a higher center where they are doing all the high-risk patients of ASA 3-4, the outcome of both the studies may not be comparable because there will be many factors which will influence the outcome, and hence try to look for that whether the population that has been included into a study is the same population that comes to your clinic or to your hospital. If they are same, yes, you can use it. If they are different, you should always think before you can apply those outcomes into a study. Also like to look for study period. Sometimes some studies are long-term studies. They were started, say, 8 years back, 10 years back, and published, say, 4 years back. But then some new drug has come up. So those older drugs may not be applicable into new parlance, though it is still a study. They may have still a better outcome. But subsequent to those studies, a new molecule, a new drug, a new technique has come up. Even though the older studies was good, but because of the presence of a newer drug, newer technique, older drug may not be, older study may not be applicable to your study. And that's why you should see the study period of the paper also, that when it has been done, and is any subsequent studies talks about this molecule further or some new thing has come up. Next important aspect is the subjects and participants. Look for which participants has been included into a study. Are the same subjects, same type of population into a clinical practice or not? If they're all ASA 3 and 4 and you're doing ASA 1, not applicable, or vice versa. So that's why I also try to look for the selection of study subjects and participants. If you are doing a study, do select them appropriately that fits into the beneficial effect of study. Prerequisites of study, tools and terminologies, which I mentioned earlier, and even for data collection. Say, for example, if you want to look for, say, for example, say BPS, as simple as blood pressure, you cannot simply say measurement of blood pressure. You have to mention it, measurement of a blood pressure using an arterial artery cannulation, using a transducer, and you will be measuring after 5 minutes of induction of anesthesia. So this means you have to define exactly how are you going to observe the data for your particular study, by what tool, at what time, and if there are other things like supine position, sitting position, those also needs to be remembered. If you are doing a study, always try to have a data gathering instruments. Usually we say a case required form so that you can record them appropriately. I mentioned when you measure anything, mention how you measure it, when it will be measured, and where it will be measured. For example, baseline blood pressure. If you measure it in the ward or in the pre-operative recovery, pre-operative holding area, or inside the operating room, there will be certain differences there. So be very clear. Next aspect is sampling, randomization, allocation concealment, blinding, masking. Now this is important because this can affect the outcome. Now we cannot research the whole universe. Best study would be that the whole universe is studied and then you come with outcome. But this is not practically possible. So you usually sample some population. Say if you are having 1,000 patients coming to your hospital, you'll be selecting, say, 50, 75, 100, 200, depending upon the sample size calculation for a particular outcome. So this sampling should be done appropriately. Sampling should not be biased. If you say, for example, some surgeon is doing high-risk surgeries and is opening on Thursday, you will say, no, we'll not pick up patients on Thursday because they are all high risk. I'll pick up a patient on Monday where they are low risk. So this type of sampling is not good because you are getting 50% high risk, 50% low risk, but you are only studying low risk patients. So this may not be applicable to whole your clinical practice. So sampling should be done so that all observation units or participants should have zero probability, should not have zero probability. All have equal chances to enter your study. And this is what is called probability samples, that all patients are given equal chance to enter your study irrespective of any other aspects if they fit into the inclusion criteria. So this is what you have done till now: target population, you study population, you study sample, and then you randomize them. When you want to use some new drug, new technique, you have to randomize. One will receive gold standard or standard of care, the other will receive the new technique, and this technique is called randomization. It is not my choice that today I will do group A and tomorrow I'll do group B. No, I should not be aware of that this patient will require whether group A drug or group B drug, and this is called randomization. And this enables a fair and unbiased comparison. And this needs to be done. There are many aspects of doing it. This is nowadays people do it by computer generated random number tables, and this needs to be done. But even this, once you have a randomization done, they should be concealed from the researcher. And this technique is called allocation concealment. If I know the technique, probably I know that this patient is going into a new drug regime and patient is sick. I say, no, I'm not doing any research today. So this again creates a bias because I have not included a high risk population into a research group or a study group, and hence my outcomes are not comparable. And this creates a selection bias. And that's why what we need to do is something called allocation concealment, so that a researcher is not aware of which group the patient will go in after recruitment. Only when you want to give some drug, some person will give you a blinded drug and then you give it and then observe it. And that comes blinding, which I come a little later. So allocation concealment must be a part of study, whether you're reading it or doing it. If somebody has not done it and you're reading paper, that paper is not good. If you are doing it, you have to do the allocation concealment. Similarly, blinding has to be done. If I know that this patient has received this study drug, I will always say, I hope you are not having pain. Patient will say, yes. If doctor is saying it, yes, sir, I am not having pain. If you say, no, you are looking in so much of pain, he will say, yes. If sir is saying, yes, it is pain. So this means sometimes if you know which group has been given, you can influence the outcome or the response of the patient. And this process is called blinding, that the person who is monitoring the data is not aware that which group drug patient has received it. If somebody has not mentioned in the study, this is not a good study. So this is called as blinding and masking. And you should look for the papers, or you should include into your papers that blind as many individuals as possible in the trial, participants, practitioners, data collection, everybody should be blinded. And also you try to look for the objective tools. You cannot look at the face and say that he's looking in severe pain. You need to use an objective tool like visual analog scale and ask the patient, how much is your pain? So this will again avoid bias in particular studies. Now we have to look for other biases also. Selection bias. Now, if there is an imbalance in baseline characteristics or loss to follow-up, so if you think that the patient population that you've selected is not appropriate, it becomes a selection bias. Measurement bias. If you're measuring blood pressure using a sphygmo manometer, you can always say 10 more or 10 less because you are hearing it. It's very subjective. Reporting bias, performance bias, similarly recall bias. If you ask a patient what happened 6 months back, how was your pain, he may not remember. So you have to give them some diary and say every day you record your blood pressure, you record your pain, and then come back to me, then recall bias will not happen. So you have to look at how the data has been collected. Observer bias. I mentioned about the BP measurements. Similarly, the other aspect is the confounders. When you do a study or read a study, look for that the patient who has been included into the study and they are measuring some important outcome. In those situations, we have to look for what can be done for them. So sometimes, say, for example, a smoking can influence, if we are looking for whether coffee causes pancreatic cancer. So this was the study. But some of the patients were smoker. And we know that smoking increases coffee consumption. Smoking also increases pancreatic cancer. So we are not very sure whether it is smoking which causes pancreatic cancer or it's coffee which causes pancreatic cancer, because we have not considered smoking. So smoking is called confounders. So look for into a study that these confounders has been removed. That is what sometimes use exclusion criteria. Now coming to the statistic, this is one of the important aspects because the statistical limitation remains paramount, even if they have done it correctly. But if the analysis is wrong, then this means if somebody says 2 into 2 is equal to 8, then 2 is okay, 2 is okay because they have something, but the outcome is they have done the wrong statistical analysis and 8 is not the correct outcome of it. So, and if it has been done to a small sample size, you cannot come with conclusion. So you should be aware of the statistical tool, and this is everybody may not learn it. So involve a biostatistician into a team so that you can understand it. But if you're a reader, you should be at least aware of these basic aspects that yes, this somebody has done the statistical tool correctly, use the correct tools for it. At least this should be ensured into a paper. And that's why these type of charts are important sometimes, which you can look for that whether the statistical tool application has been correct. These are usually software based. You may not be doing it, but you should be aware of it. Similarly, when we say statistical part, people mentions p-values, confidence interval. If you see the IJA recent articles, we have made it mandatory to have confidence interval because p-value is not the everything. P cannot be the sole aspect. Sometimes show you that certain things where P significant, but if you see the values in more details, you find that both are comparable. There's no difference, even though the P may be significant. So this all depends on many other factors, and that's why we should be cautious when we're doing it. One important thing is when you read a paper, even if says p-value is 0.001, highly significant, so group A is better than group B, but this may not be always right because there could be some clinical issues. For example, if you compare say two type of laryngoscopes, they are in a normal airway without any respiratory compromise. If the values come 14 versus 18 seconds for intubation, and if p-value is even say 0.01 or 0.001, this may not be very good, right? Because the difference of 4 seconds in a patient of a normal airway with respiratory status reserves, difference of 4 seconds is not of any clinical significance, and hence you should interpret it appropriately. And sometimes if we add 95% confidence interval, though there will be a significant difference between the mean and standard deviation along with p-value, but if you see this 95% confidence interval, they are non-significant even. You can see the values 12 to 18 seconds is overlapping with 14 to 20 seconds. So you do not know which group is better. So sometimes that's why we have to understand the mean and standard deviation along with 95% confidence interval. Sometimes people do multiple subgroup analysis. In research, usually we accept 5% error acceptable because we cannot have 100% accuracy. For 100% accuracy, we have to study the universe. We cannot study the universe. That's why we accept 5% error is acceptable. But when you do a subgroup analysis, this 5% error becomes 10%, 20%, 40%. And we cannot accept 40% error in a research. Minimum acceptable is 5%. And that's why these type of multiple testings can lead to more amount of errors, which is non-acceptable. There are certain charts. These are called critical appraisal charts. I will request you can download from your, or I can share with you. Whenever you read a paper, just read these things and see whether this paper has included this thing. And then you try to adapt this paper into a clinical practice. So these are critical appraisal. And then you can go ahead and change your clinical practice. Assess the risk of bias and decide if the results are trustworthy in that published paper, and then change it. Now, the last couple of slides, just validity. We say internal validity and external validity. Internal means that the paper or the research has been done in a correct way. It's repeatable. Everything is blinded, no bias. The tools have been used appropriately. So these called internal validity. If the population selected is applicable to the journalized population, if I do a study in 100 patients and I say confidently that all the patients coming to my hospital, 1,000 patients, this outcome is applicable, this is called external validity. So this all depends upon to the extent which results apply outside the study technique. And you need to assess that what type of population, what type of patients, what type of their profile, comorbidities, are they applicable to your population? If yes, external validity is good. And that also needs to be looked for. So to summarize, everyone, their clinical practice should be aware of the basics of research. If you are just study the research to bring change into clinical practice, be very cognizant basics and try to critical appraise a paper, which is simple but needs to be learned. Learn it appropriately to accept the new science into a clinical practice on this basic background of research, which is very, very important. Keep yourselves updated and give the best possible care to your patients. Thank you once again, and greetings from the Indian Journal of Anaesthesia, which is publishing papers in anesthesiology, critical care, and pain medicine, and all you can download freely from the IJA website.